Thanks so much. And I just want to start by saying that was a fantastic presentation, Rachel, and I'm so happy you're doing this work. And I really wish I'd had that measure for my work, and I look forward to seeing it progress and to getting it into a usable form. And I'll talk about a measure that I used, which got me close to some of those aspects, which is actually validated. I don't know if you've come across it, but it didn't get me all the way, and I'm really excited that you're doing that work. So the title of my talk is Engaging Women Veterans Through a Patient-Facing Web-Based Reproductive Planning Decision Support Tool, a pilot study in VA primary care. And by way of brief background, we have a large body of epidemiologic work that tells us that women veterans of reproductive age face increased risks of poor pregnancy outcomes due to a number of factors, including high rates of medical and mental health comorbidities, a high burden of psychosocial risk factors, and also high rates of unintended pregnancy. So to improve pregnancy outcomes, the CDC recommends that we provide routine delivery of reproductive planning services in primary care. And what does that mean? That means that we talk to women in a routine way about what their pregnancy desires and goals are, and then we provide tailored services that can help them to achieve those goals. And that might be preconception counseling for women who have pregnancy on their horizon, or contraceptive counseling and care for women who wish to delay and defer pregnancy. Unfortunately, data indicate that in VA, only about 38% of veterans who are at risk of pregnancy have discussed contraception and or preconception health with their primary care provider in the past year. And qualitative studies indicate that their discussions are often perceived as failing to incorporate their perspectives and needs. So to address this, we developed the MyPath tool. It is a patient-facing, web-based decision support tool, and it's indicated and designed to be used by patients before their primary care visits. And our thinking behind using the tool was to say that it's really hard to change provider behavior. So maybe if we can empower and engage veterans in these interactions, we can actually improve care without having to go to providers, right? Because we know that it's oftentimes those interventions go nowhere because providers are busy. So what MyPath does as women work through the tool is to elicit their reproductive goals with a short set of questions. It builds knowledge and addresses common misperceptions across fertility, preconception, pre-pregnancy health, and contraception, and women can kind of choose the sections that are the most relevant to them in their situation. It facilitates selection of a birth control method that's aligned with preferences and needs, and this is kind of more standard shared decision aid to facilitate shared decision making, that section, because it is a discrete preference-sensitive decision to choose a contraceptive method. And then the tool generates a summary page that can be printed or emailed and brought to a visit to facilitate conversations with providers. I just want to point out veterans were engaged through all stages of the development process of the MyPath tool. This is a picture of some of the members of our veteran engagement group, which named itself the Women for Women Veterans. They were involved in advising us from the beginning of development through our testing. And we also did extensive interviews with veterans along the pathway of developing the tool. We did cognitive interviews and user interviews to make sure that we could iteratively improve and refine the tool before we piloted it. So we then did a pilot study of the MyPath tool in a real-world clinical practice setting. We did a non-randomized sequential 2-arm pilot study with 28 women in a control group and 30 in an intervention group. We recruited veterans who were of reproductive age, so age 18 to 44, who had a scheduled primary care visit with one of 8 providers in our women's clinics in Puget Sound. And we included women who could become pregnant but were not currently seeking pregnancy, because we were looking at contraceptive outcomes as well. And we asked that we wanted to make sure that they wanted to talk about their future, either their future pregnancy desires or contraception at the visit. We sent letters to women who were scheduled for visits with an opt-out postcard and followed that by a telephone invitation to participate for for those who did not opt out. And our main objective was really to look at acceptability and feasibility, but we also measured some efficacy outcomes, which included reproductive planning discussions, provider-patient communication self-efficacy, contraceptive decision quality, and method choice, to name a few. This just depicts the study procedures. So we had women come to their visits 30 minutes early. During the control phase, before we introduced the tool into clinics, we had them meet a research assistant, do a baseline survey on an iPad, then go interact with their provider and come back and do a post-visit survey. For the intervention phase, we just added in the MyPath tool. So they did their baseline survey, then they used the MyPath tool. We printed out a summary page, handed it to them to bring to their visit, and then we surveyed them after their visit. So we had some really great results in terms of acceptability. So 97% of veterans who used the tool felt that they learned new information, and 83% felt it helped them to get what they wanted out of their visit. 93%, so nearly all veterans, would have recommended it to another veteran. And when we talked to providers, we were happy to see that none of the 8 providers felt that it significantly increased their workload. Just a few quick comments that were write-ins in our survey. It's a great primer for your appointment. I really wish this was something that existed for all appointment types within the VA so you can go in prepared. And then a representative quote from a provider: it helped vets to think about their contraceptive options before the appointment, which made our discussion more targeted. So this just shows the frequency of reproductive planning conversations in the visit. And so in the intervention group, 92% of women reported they discussed either preconception or contraception versus 68% in the control group. And remember that these were all women who said they wanted to discuss this topic going into their visit. This table shows some of our results for selected patient-centered and clinical outcomes. And so the first 2 columns show the baseline to post-visit changes in the survey items that we looked at. And so if you look at the first variable, and this is provider-patient communication self-efficacy, which includes some of the questions that Rachel was sort of getting at around, like, do you know what questions to ask your provider? How comfortable are you, or how likely is it that you can get your provider to help you to meet your needs, and those kinds of questions. And it's actually a validated scale that's been used in older adults, a 5-point scale. And so in the intervention group, we saw a positive 8-point increase that was statistically significant from pre to post. We looked at family planning knowledge and used a 14-item assessment, and also saw a significant increase in knowledge of 1.7 points. We saw a significant decrease in contraceptive decision conflict of 23%, and that's a dichotomized variable based on a scale. And then we also looked at whether or not women were switching to effective methods from less effective methods. And that's not necessarily right for all women, but we were thinking that we would be reducing barriers by giving information about all of the variety of methods that women have access to. And if you look at the control group, you'll see that there are small increases and a decrease in the right direction for decision conflict, but none of those were significant. And when we compared the change across the groups in that last column, you can see that the gain was significantly greater in the intervention group for the first 2, with a trend in contraceptive decision conflict. So summary findings: MyPath we found it was highly acceptable to veterans, did not increase providers' perceived workload. Preliminary data suggests that it increased the frequency of discussions and improved decision quality. And I also didn't put this on the slide, but communication self-efficacy, which we were really excited about because, again, that's really representative of women's ability to get their needs met, to be able to talk about what their values and preferences are around these issues, so that the conversation is more patient-centered. And we concluded that additional testing was warranted, both to assess effectiveness and implementation outcomes in a larger sample. And so I'm happy to share that we just got an IAR funded to do a multi-site hybrid type 1 randomized control trial in partnership with Women's Health Services and the Women's Health PBRN. We are going to try innovative delivery strategy. We concluded that having the idea, when I first started this work, there was talk about how iPads were going to be available in clinics to help veterans navigate their visit, right? That was like super, and I was like, oh, this is great. I'm just going to link onto that effort. Well, let's say that like 5 years later, that's not happening. And we really recognize that it's going to be hard to scale anything that requires a clinic to have iPads available. And again, this is one issue. Primary care providers deal with 100 things. This is reproductive health. It's one thing. It's an underrepresented issue, but it's not the only thing. And so what we're going to try, and actually we're doing pilot testing on this right now, and it's working, but we're going to send the link to women veterans before their scheduled appointments, actually embedded in a vet text appointment reminder. We're going to give them also a heads up that it's coming and that's where it is. But it's a way of getting a link, and they can use the tool. As you can see, it's now formatted for a desktop, an iPad, and also a smartphone. So they can use the tool, they can email themselves the summary all on the smartphone. And so that's our goal for sort of being able to do something that's scalable and that is low cost and that we could actually maybe, replicate, unlike a lot of the studies that have studied these kinds of tools. So I want to spend a minute just with my acknowledgments because I know I'm out of time. But my funding, I'm funded by an HSR&D CDA. I have I've gotten great support from CHIRP, one of my mentors, Sonia Barrero, is at CHIRP, and they supported this project along with Women's Health Services. I want to call out my fabulous mentorship team. Kari Nelson is back there in the audience. She's one of my primary mentors. Sonia Barrero, David Arterburn, I think Allison's right over there, Allison Hamilton, and then my operational partners, Sally Haskell, Alicia Christie, the Women's Health Network, who are endlessly supportive of me and my work, Becky and Susan, and then all of my colleagues back at home, including Jody, who's in the audience, and others. So thank you. And then we can do more at the end. Okay, I can take, it sounds like I have time for one question. Yeah, go ahead.
How have you prepped providers to have this discussion?
Yeah, that is a really good question. And a tricky one, because again, we were trying to do as much low touch with providers as possible just to make it more easily replicated. We do an orientation of like what the tool is, and we have so we have a guide that for providers with a number of resources and links for where they can send people. So if they're less comfortable having a conversation about preconception health, they can send, then it's refer or go to these resources. We also have funding actually through Women's Health Services to create a dissemination page, which we're in the process of doing, which will have all the resources. So we're hoping that will be a resource for providers to say, if you're going to use this tool in your practice and people are going to come with the summary page, here's where you can go. If you don't feel comfortable talking about these things, here's some resources or refer. And we hope that this will start a conversation to enable women to get referred to gynecology, because you need a referral to get to gynecology, and a lot of these issues are things that can be and should be addressed by gynecology.